outset, I thank Dr. Jyotidev and his organization to inviting us to chair this section. So today's topic is Protect Fast and Protect Early. The speaker is Dr. Sirshendu Pal from Siliguri, and I invite him to deliver his talk. So he is a consultant physician and diabetologist from Siliguri, and he did his post-graduation from Calcutta Medical College, and he is a fellow of Euro-Asian Academy of Cardiology and fellow of International Medical Sciences Academy, and to his credit, he has written papers in international and national journals, and he is the author of many book chapters. And over to you, sir.
Moving on to the management of diabetes over the years, we have come a long way. Initially, diabetes was diagnosed by finding glucose in urine, and nowadays we are trying to cure diabetes by driving out glucose in the urine through SGLT2 inhibitors. We have indeed come a long way. So diabetes scenario in India, it starts at a very young age. Indians have low beta cell mass and high insulin resistance. Micro and macrovascular complications appear early in Indians. 1 in 3 patients with diabetes will have early onset of CVD. Only 36% of Indians achieve good glucose control. And CAD accounts for more than 80% of all deaths and 75% of all hospitalizations in diabetic patients in India. We are different quite a lot from the others. As you can see, the prevalence of CAD in a patient with impaired glucose tolerance, with hypertension and dyslipidemia, the prevalence of CAD in Indians reaches 25%. The complications, neuropathy found in 17.7% of patients, retinopathy in 13.7% of patients, and nephropathy in 18.2%. Micro and macrovascular complications appear very early in Indian patients. So let's define our goal. We should not only try to control the diabetes, but prevent complications and give our patient a good quality of life, not only increasing in life, but letting him live healthily. Prevention of macrovascular complications like retinopathy, neuropathy, and nephropathy. Prevention of cardiovascular complications, which is a major driver of mortality. Also, we have cerebrovascular and perivascular major complications. Relief from symptoms of diabetes and improvement in quality of life. All these should be looked into while you treat your patient or manage your patient. So, a summary of a current understanding, you see here a number of trials, right from the UKPDS, the initial trial, where you included only newly diagnosed patients. And it not only gave us the theory of the legacy effect, but also showed, yes, if you tightly control your glucose, you reduce macrovascular complications. So also the other trial, the ACCORD trial, advanced trial, VAT, and the DCCT. But as we move forward in the years, we found, and a follow-up of the prolonged UKPDS trial and the VADT trial also showed that tight glucose control has a positive effect on CVD and mortality in the long term also. Coming to diabetes-related complications which appear early and accumulate rapidly in almost 60% of patients despite background therapy. There is a very important two-day study published in NEJM in 2021. It was the largest therapeutic trial in adolescents with type 2DM. It included 500 participants. And you can see how poorly we control our sugar patients. Initially, in the initial stage, you can see even in 3 years, the glycated hemoglobin is found in 20% of the patient. That is raised to 37% of the patients by 6 years. By 9 years, it touches 45% of the patients having glycated hemoglobin of 10%. Remains at 45% up to 12 years, and then probably it diminishes when the utility is much less. If you control diabetes well in the first 2 to 3 years, you'll be giving the patient maybe 10 or 15 years more, but it's just the reverse, as you can see here. So the complications set in. What are these? Hypertension, cumulative incidence found in 67.5% of patients. Kidney disease found in 54.8%. Cumulative incidence of dyslipidemia in 51.6%. And cumulative incidence of neuropathy in 32.4%. So, we should start early and go for a tight control. Macrovascular complications start developing much early, even during the pre-diabetes stage. We had known this earlier but didn't perhaps delve into it. We all know atherosclerosis starts at 2 years of age. And 1 in 3 patients with diabetes will have early onset of CVD. Traditionally, we had stressed on the sequential therapy, and we know the pitfalls of it. The A1C remains high for a much longer duration, and so now we have shifted to the combination therapy. The proactive management with brings down A1C much faster, leading to lesser complications. So, this is very important. The decision cycle for person-centered glycemic management in type 2 diabetes. This gives you an overview of how to manage a diabetes patient throughout his life, throughout his years, 30 or 40 years of his life. First, assess key person characteristics, the individual's priorities, current lifestyle and health behaviors, comorbidities if he is having CVD, CKD or heart failure, clinical characteristics, his identification data of age, weight, issues such as motivation, depression, or cognition should be looked into. That helps to manage the patient well. Social determinants of health, his relation to his peers, to his social barriers, so on and so forth. Consider specific factors that impact choice of treatment, individualized glycemic and weight goals, impact on weight, hypoglycemia and cardiorenal protection, underlying physiological factors. Yes, if he's an athlete, you have to give medicines accordingly, or you have to give insulin accordingly. He is a chartered accountant, he is a businessman, he is a fruit seller, all define their management. Side effect profiles of medicines, whether he can tolerate the medicine, complexity of regimen not understood by very uneducated patients, regimen choice to optimize medication use and reduce treatment discontinuation, and overall accessibility, cost and availability is very important. Utilize shared decision making to create a management plan, ensure access to diabetes-centered medical education, diabetes-specific medical education, involve an educated and informed person, explore personal preferences. Yes, very important. A patient may not be fond of a molecule which causes diuresis. Language matters. Please try to overcome language barriers, include motivational interviewing, goal setting and shared decision making. So, look for SMART goals. The goal should be specific, measurable, achievable, realistic and time limited. Implement management plan through a regular review. The diabetes specific medical education should be reviewed regularly, not only at the first sitting. Provide ongoing support and monitoring of emotional well-being so that he continues his medication and lifestyle modification. Tolerability of medication, biofeedback including the BGM, CGM, weight loss, step count, A1C, BP, lipids control, all are very important. And finally, review at least once or twice a year, mutually agree on changes and ensure agreed modification of therapy is implemented by the individual in a timely fashion to avoid therapeutic inertia by the patient as well as the physician. Coming to the prototype molecule gliptin, sitagliptin, very often used in Indians. We all know 77% of Indians do not have adequate glucose control as per the TIDE study. HbA1c reduction with sitagliptin overall was 1% world over, but in Indians it was 1.4%. Fasting glucose reduction with sitagliptin was 1.7 millimoles per liter, while in Indians it was 2.2 millimoles per liter. Perhaps it works better in Indians. Coming to the prototype molecules of gliflozin, the dapagliflozin, the cardiorenal benefits in diabetic and non-diabetic patients. It has a cardiorenal protection independent of glycemic levels. There is 17% reduction in CV death or hospitalization from heart failure, significant reduction in CV death despite background use of CV medication, as I detail in a study later on, 27% reduction in hospitalization from heart failure. and it can be used in all stages of heart failure. Please remember, SGLT2 inhibitors can be used in all stages of heart failure, and perhaps it can also be used in all stages of kidney failure from the past few months report we are having. Reduction in CKD progression by 44%, renal progression progressively attenuated, the weight reduction by 2 to 3 kilos. Cardiorenal protection in non-diabetic patients. Yes, dapagliflozin reduces CV death and heart failure in patients with diabetes and without diabetes, 25% versus 27%. In CKD patients, dapagliflozin significantly reduced eGFR, decline was 39%, and it's approved to reduce the risk of CV death in heart failure patients. So, you can see it ticks 7 of the 8 boxes. Sitagliptin with dapagliflozin with metformin, if you use, you can control 7 parts of the 8 ominous octet. Only one left behind, that's the neurotransmitter dysfunction that we can control with the GLP-1 agonists. The combination is very useful. Why? Most of the actions are complementary. Metformin, we all know, increases the anabolic glucose metabolism. In the liver, it reduces gluconeogenesis, reduces glycogenolysis and fatty acid oxidation. In the skeletal muscle, it increases insulin-mediated glucose uptake, increased glycogenesis, and increased fatty acid oxidation all leads to reduction in blood glucose levels. The SGLT2 inhibitors working on the kidneys drives out glucose from the body together with sodium and water. That's why we have a reduction in blood pressure as well. Also the reduction in the fat mass. In the pancreas, it increases the beta cell sensitivity. So SGLT2 inhibitors should be started early to get the full benefit of it. And it increases glucagon levels. The DPP-4 inhibitors increases the insulin secretion but decreases the glucagon levels, so its actions are complementary. And obviously, it increases the incretin effect by reducing its biodegradation by the DPP-4 enzymes. So all these leads to reduction in the hypoglycemia as they complement each other. Clinical evidences, this is a very good trial showing combinations of SGLT2 inhibitors. Here they use the empagliflozin together with linagliptin as second-line therapy in subjects with type 2 diabetes inadequately controlled with metformin. All combinations of SGLT2 inhibitors, EMPA were used, 25, 10 with linagliptin 5 or solely with itself as 10 or 25 milligram or DPP-4 linagliptin as 5 milligram. And it was found that triple drug regimen scored over the others, provided greater glucose lowering efficacy than the individual components with a low risk of hypoglycemia. Triple therapy with low dose SGLT2 inhibitors plus DPP-4 versus dual therapy with each monocomponent all added to metformin in uncontrolled type 2 diabetes. Yes, the triple drug regimen is found to be better than double drug of SGLT2 and metformin or DPP-4 and metformin. The benefits of weight loss is better than the dual therapy with addition of either monocomponent to metformin and was generally well tolerated. So, triple therapy scores over dual therapy. One Indian study over 16 weeks, 274 patients divided into 2 groups, 137 each. One group had DEPA with SITA and metformin, the other had SITA with metformin only. And the fixed dose combination therapy, triple drug, produced statistically significant reductions in HbA1c, fasting glucose, and 2 postprandial glucose compared to the dual therapy. A note on DAPA. Dapagliflozin effect on cardiovascular events, thrombolysis and myocardial infarction. This is a famous DECLARE-TIMI trial. Patient population, HbA1c 6.5 to 12%, who had or were at risk of atherosclerotic cardiovascular disease. Dose of DAPA, 10 milligram. And you can see it was compared with the placebo. The HbA1c reduction was better with DAPA. Similarly, the weight reduction was also better with DAPA. Efficacy and safety of dapagliflozin according to the background use of cardiovascular medications in patients with type 2 diabetes. It was this what I was telling earlier. You can see here dapagliflozin was given as an add-on to a patient who had been receiving already ACE inhibitors or ARBs, beta blockers, diuretics and MRAs. But even then, DAPA showed additional benefit. Dapagliflozin consistently reduced the risk of CV and kidney outcomes irrespective of background use of various CV medications without any treatment interaction for key safety status. So you can use it as a molecule even non-diabetic patients for its kidney effects or for its cardiovascular effects, the DAPA or the EMPA. In fact, EMPA has a better profile nowadays, as you can see for the latest trials. Similarly, sitagliptin, cardiovascular outcomes and mortality in patients with type 2 diabetes mellitus. The key message from this trial also, sitagliptin had no effect on cardiovascular death, macular infarction, stroke or unstable angina. Thus, it was indeed CV neutral. Total patients 14,671. This is a very good study. And then we have these two studies. The persistent study on sitagliptin findings demonstrated that sitagliptin add-on to insulin was useful in type 2 diabetes patients with poor glycemic control, irrespective of the insulin regimen. And data obtained by Wikipedia's risk engine evaluation score may be appreciated by patients and clinicians in realizing individual CV risk and its evaluation during time. So, coming to the guidelines, the guidelines started changing from 2022. On the left, you can see the standards of medical care in diabetes 2022. It stated that if A1C values are more than 1.5 to 2% above target, early combination therapy can be considered in some patients at treatment initiation to extend the time to treatment failure. On the right, the guidelines by the American Association of Clinical Endocrinologists, the 2022 diabetes guideline update, which again stated if A1C values are more than 7.5 to 9%, recently diagnosed with type 2 DM, unlikely to attain the A1C target with a single agent, early combination pharmacotherapy should be considered. Newly diagnosed persons with type 2 DM and an entry A1C more than 9% and or 1% above target, one should initiate along with lifestyle modification, dual or possibly triple combination therapy, including metformin. Then comes the ADA ASD consensus guidelines in 2022, and it propounded the combination therapy again. Choose approaches that provided the efficacy to achieve goals. Metformin or agents, including combination therapy that provide adequate efficacy to achieve and maintain treatment goals. But please do try to avoid hypoglycemia, and as a priority in high-risk individuals, especially in the elderly. Be cautious. These are the alternatives. In page 25 it's given. Consider initial combination therapy with glucose-lowering agents, especially in those with high HbA1c at diagnosis, that is more than 70 millimoles per mole, or that is 8.5% A1C. In younger people with type 2 diabetes, regardless of HbA1c, and in those in whom a stepwise approach would delay access to agents that would provide cardiorenal protection beyond than their glucose-lowering effects or glycemic-lowering effects. And finally, the next year, ADU 2023, the entire things changed. They shifted from not only from combination therapy, we went one step further, asking for risk reduction, that's cardiorenal risk. First, if the patient has atherosclerotic cardiovascular disease as per the CVOT trials, or if they are patients at high risk, definition may vary, but more than 55 years of age with 2 or more additional risk factors, obesity, hypertension, smoking, dyslipidemia, or albuminuria, start with SGLT2 inhibitors or GLP-1 receptor agonists, whichever you choose. If not controlled, you add the other one, or if not tolerated. And next, you can also use the thiazolidinediones, but not in heart failure or renal failure, but it is good for stroke patients. In heart failure, SGLT2 inhibitors are the best, but you can add the GLP-1 receptor agonists. For CKD progression, best is SGLT2 inhibitors with primary evidence of reducing CKD progression. If not tolerated or contraindicated, go for the GLP-1 receptor agonists. If you want to say above targets, consider others. And then go for specific glycemic management goal. The most highly efficacious ones are the GLP-1 agonists. The best is perhaps tirzepatide, then the semaglutide with insulin. Next in line with efficacy comes the sulfonylurea reducer, metformin, and last is DPP-4, which has less efficacy. In weight management, again, GLP-1 agonist score, best is tirzepatide, second is semaglutide, next comes liraglutide, and then in the intermediate list are the rest of the GLP-1 agonists are the SGLT2 inhibitors, and the neutral one is DPP-4 inhibitors, metformin. Though metformin also reduces weight, it reduces weight up to 2.6 kilos. There are many good studies on that. Anyway, sorry. To summarize, address multiple defects of type 2 diabetes with combination therapy. The combination therapy exerts synergistic pharmacodynamic effects, is safe, rapid, and sustained glycemic control is achieved, improves both insulin resistance and beta cell functions, delays the need for insulin, helps reduce body weight and blood pressure, low risk of hyperglycemic episodes, reduces pill burden, and of course, a combination therapy is cost effective. Thank you for your kind attention.